Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. Despite having more treatment options than ever before, narcolepsy remains significantly underdiagnosed. Is there a potential clue on the polysomnography that we might be overlooking? Dr. Alyssa Cairns is a sleep scientist at BioSerenity, and she has combed through more than 500,000 sleep records. She looked at the predictive value of a PSG SOREM for a future diagnosis of narcolepsy. She is the chief scientist at BioSerenity, where her team is exploring the biophysiological phenotypes of sleep disorders, specifically the central disorders of hypersomnolence. She was trained as an RPSGT prior to obtaining her doctorate in psychology with an emphasis on sleep medicine. She is here to tell us about her work examining SOREMs on a PSG. Thanks for joining us today.
Thank you for having me. Delighted to be here.
That sounds like a lot of records. Was that kind of your job? Were you sort of tasked with organizing them?
You're right. A lot of records. A lot of records. It wasn't tasked directly with organizing them specifically, rather just kind of making sure that certain things were being addressed as that process went on. And I wasn't necessarily the one that kind of came into it with this desire to do that particular thing. What happened was my prior life, coming from an academic background, postdoctorate at Brown University, then did some clinical work at Johns Hopkins. And I was like, gosh, there's something missing here, right? How we have academic work, all of the wealth of academic work that we know, cutting edge, really great material, rigorously conducted and published. And then there's like this discrete difference with how that information then gets communicated to how we apply it to the practice to actually help people, the humans of the world. And so I took this, what I call the great leap of faith, right? Right, this huge leap, this leap of unknown from, the sort of grant writing, NIH grant writing realm in academia to this wild unknown of what we kind of now consider translational medicine, which is this sort of intersection of, academic work and how we apply that academic work into the clinical realm. And so I took this huge leap by writing a grant to work with a very large company at the time, 2013 Sleep Med, to really get in there and start to really sort through these records of real world data sets. I had no idea how many they had, right? When I got there, I was pleasantly surprised, a bit overwhelmed, but excitingly, I love a challenge. So I found that they had, at the time, close to 1 million records of raw data sets. And so in the process, going through these data, I was like, golly, there is so much to be explored here with this real physiologic data on real humans from multiple years, right? 2004 up until, current, essentially. And they can give us a lot of information. It's a lot of power to be able to, predict diseases or to identify subtleties, nuances in phenotypes, endotypes, efficacy of different treatments, right? But also just generally speaking, the evolution of sleep in the general clinical sort of sleep atmosphere. So I took on that challenge and that's what got me there. I took, several years in helping parse these data, this enormous data set into essentially bits and pieces of usable or what we consider kind of less usable data sets. And so that's what I've been doing since 2013, just kind of continuously writing grants, continuously having epiphanies of what we could look at based on what we see, but also the zeitgeist, right? What are these questions that are really pressing in these gaps of need, to address really relevant, pressing questions that can't really be addressed at the larger scale, right? Because you need a lot of power to be able to look at certainly these more rare diseases, right?
So you mentioned epiphany. And so I'm wondering, how did you think to look at SOREM on a PSG if it wasn't followed by an MSLT?
Great question. So it was really the zeitgeist, because in 2013, the criteria for including the nocturnal polysomnogram REM onset into the quantification of the number of REMs that one must have to qualify for quote unquote narcolepsy with the MSLT, that was changed with the ICSD modification in 2013.
Mm-hmm.
And so my question was, well, how frequent is this? Right? How many people have we missed? If we were to look retrospectively and were to count that singular nocturnal polysomnogram, REM or short REM latency into the MSLT, if they had one, how many people have we missed diagnostically, right? So that was kind of the impetus for that particular grant, and so that's what I wanted to do, is, again, because you need a lot of power, a lot of subjects to be able to identify the incidence of it, and that was kind of question one.
And did you define the PSG SOREM the same as ASM? Like, how did you define it?
We did. We followed the rules that were published based on those 2012, 13, 14 manuscripts that were published on essentially hypocretin deficient with or without cataplexy, manifested cataplexy, that have identified that REM onset within 15 minutes of sleep onset, which we call a sleep onset REM or sleep onset or SOREMP, we would consider that to be kind of that diagnostic threshold, if you will, with the highest sensitivity and specificity for predicting hypocretin deficiency, right? And again, it can be with or without cataplexy, essentially. Sure.
So why is it 15 minutes for PSG SOREM, but 20 for an MSLT?
So it's the same, right? So if you think about the MSLT, we give individuals 20-minute nap allocations, right? So it's a time in bed allocation, but the rules are still the same as far as 15 minutes, right? So it's 15 minutes from sleep onset latency. Do we want to kind of evaluate that period of time for that whole 15 minutes? Does REM occur? Does it not occur? Does sleep occur? Right. Of course, if REM occurs, sleep occurs. But right. So it's actually the same rules, and perhaps that was just, kind of parsimonious, was just to kind of keep the rules the same, right? But yeah, I think that is one of the common questions that come up: is 20 minutes during the day, but 15 minutes at night. But it's actually 20-minute nap allocations during the day, but it's really 15 minutes from sleep onset is the period of time that is looked at or evaluated for both sleep and REM for the MSLT, but also the PSG.
So did you, when you were looking at this specifically, were you kind of divvying up the sample by symptoms, or was this just everyone that you had?
So we did it actually both ways.
Okay. So
we looked at all comers, right, just to kind of get almost an epidemiologic litmus test of how common is it as a manifestation, right? So all comers, those who come in without sleepiness, without symptoms of sleep disordered breathing, many of whom manifest as sleep disordered breathing, kind of just that's the nature of the sleep clinic population, across a wide variety of demographic factors. So all comers, meaning those who didn't have an MSLT subsequently, meaning the next day. So we looked at the incidence, prevalence, predictive factors, right? Were there predictive factors in having the sleep onset REM period? Because that's one of the common things that kind of gets in the way, I think, of a lot of practitioners, is that, if somebody has a sleep apnea manifestation, even if it's an AHI of 6.5, perhaps that's why they had a sleep onset REM. And that's likely not true, right? So it's a very complicated, competing process to have REM within 15 minutes. It has to be something amiss with that flip-flop switch. We know that now. But back to your question of, did we do it kind of all comers or a curated sample? We did it both ways. We had first all comers, and then the second group was really the ones who we thought perhaps would be more likely to have a sleep onset REM, which are those who had subsequently the next day an MSLT. And indeed, that's exactly what we found. So the incidence of sleep onset REM in the sort of general sleep clinic population is somewhere around the 0.07, 0.08%, but it's about 3, 4, 5 times that in those that have the MSLT, especially if they have REMs on the MSLT. So again, sort of strengthening that association of that REM circuitry interruption, if you will, in those who have the sleep onset REM at night as well as during the day.
So this wasn't all just retrospective, right? You kind of did this ongoing. And so what I'm kind of wondering is how did it work? Like if I was an interpreting physician, how would I know that this had been flagged?
Yeah, so that was actually, there were 2 different studies. So we did sort of, one was a retrospective analysis of that huge repository of data. Again, all comers and those who had the MSLT. But then we were like, okay, this is important, right? Collectively, we need to address this or at least assess what's happening in the clinical field right now when physicians are faced with this information that a sleep onset REM occurred for their patient. So that is what then, kind of made us create this new study, which was a 3-year-long prospective study. It was observational only. We did not intervene. But what we did do is we programmed an alert to pop up when we detected the sleep onset REM, because we knew as the scientists that this was clinically meaningful for that patient, and could be folded into potentially the clinical correlation pathway or the next diagnostic steps or treatment steps for that person. But we first needed to see how physicians were going to be, I guess, behaving when given the information. So as you know, the typical report in any interpretation template gives you REM onset latency as a continuous variable, right? So REM onset latency of 120 minutes or 75 minutes, but nowhere does it call out like a dichotomous threshold, for example, meaning this person had a sleep onset REM 50 minutes or less. So we were like, well, that's like an easy thing to do, right? So let's just go ahead and build that. And so we built that and we said, if it's 15 minutes or less, it's a specific, let's call it like a flag or a banner or a call out. And then the physician would decide what to do with that information. And we just simply watched like little birds on a tree, really. And we watched for 3 years. So we watched individual patients go through the pipeline, and we watched to see what would happen to that patient, but also what did the physician do when they were given the information? Did they say that this was an important piece of information to synthesize into the interpretation so that it is in the notes for further evaluation? Did they perhaps not say a thing at all? Did they perhaps say, you know what, this person has an AHI of 7, but their Epworth is 23, given the fact that they have a sleep onset REM as per this new paradigm that was put out in front of us, let's go ahead and have this evaluated aggressively, right? So we were really observational, and we just wanted to see what was happening, right?
Did they know this was happening, or did they just get an alert one day?
So all of the participating physicians and the hospital systems that participated in the program were in our clinical sort of network, right? As Sleep Med BioSerenity. So we had the ability to tap into this very large group. If you think of this, the United States, a very large heterogeneous group of laboratories and hospital systems to opt in, because essentially it's a choice. They didn't have to do it, but we did. We of course IRB approval, and then we presented the hospital system and the physicians with essentially a consent form, right? Because they could opt in or opt out.
Okay.
And so they did have some, let's call it some kind of onboarding information, just de facto because they had an informed consent. They were given the opportunity to participate, and some didn't want to participate, and that was fine, right?
Interesting. Did most opt in?
Most opted in. Yep. Yeah.
So this is really interesting, right? Because now you're kind of talking about something on an overnight polysomnography. And so it kind of reminds me of some of the work Dr. Mignot's been doing, where he thinks that maybe we will ultimately be able to identify people who have narcolepsy based on their overnight PSG, with his work on hypnodensity. So what do you think about that? Do you think that's possible?
I think it's more than possible. I think it's actually going to happen, right? I think that's where we all want the field to move. I think that we want the field to move in that way so that we can not be so reliant on tests that, especially for example, the disambiguation of narcolepsy type 2, or without that information that a biomarker can give us. And the ease of access to that biomarker, for example, hypocretin, right? It's like you have to do a spinal tap to get that. So it's not necessarily somebody's going to sign up for that, very freely. So without that, we need to have something that is more, simple to acquire, but also to sort of informationally digest, so that we can utilize it in a meaningful, easy way without perhaps having to go through other impediments like the insurance verification, pain, right, to the patient, and things like that. But I think that based on the wealth of information that we are seeing right now in the central nervous system hypersomnia sphere, with machine learning and the different tools that are out there for, algorithm-based tools to digest and compose the likelihood that somebody has a REM dysregulation process vis-a-vis, right, maybe it's narcolepsy that is hypocretin deficient narcolepsy. I think that that's exactly where we're going. And the question is when are we going to get there, right? And I think that's going to be at a place where we have consensus of the minds and of the tools, right?
It always strikes me as being kind of funny that on one hand, we're really advancing in one direction, but yet on the other hand, we're totally going the opposite way. And what I mean by that is, look at all of this cool information we can get from the polysomnography. And yet in our clinical practice, insurance kind of forces our hand to do an HSAT.
I know it.
And then if we think out, right, that if we have, smaller labs that close, then we are kind of relegating this testing to academic centers. Tertiary care referral centers. And then, that's not great for access to sleep care.
It's not. It's terrible. It's an atrocity, frankly.
It is.
And it's really an atrocity, especially if you look at just, sort of boiling down, because I've worked on both sides of this fence. And so I've heard the rationale from these, disruptive care, thought-provoking individuals that are saying that 99% of the time it's just sleep disordered breathing, so why not do an HST, right? And I get that point. So then you can get more care, allow more care via the HSAT. But then what do? It's a waterbed effect, right? So you're missing out on the nuance that the PSG, the electroencephalograph data, can actually provide for those individuals that, right, they might not have sleep disordered breathing, or it might not be the core of what's causing their excessive daytime sleepiness, but it's something else that we're missing. And these people go, we know by literature that the needle really hasn't moved that much, right? For narcolepsy, as far as from symptom onset to diagnosis, it's still hanging around 10 years. And with employing HSAT, through these tertiary care centers, and like you said, relegating and having to go through insurance verification, and then them saying, no, you have to have an HSAT, you are incredibly handicapping these people that suffer.
Well, and kind of like you pointed out, right? If an HI of 6.5, right? But there is a PSG SOREM. I mean, how often will that patient then get put on treatment and then maybe they feel better, right? But not all the way better, but they don't know that maybe there's some other thing. And if that had been HSAT, we wouldn't have known about that SOREM.
Exactly, right. It wouldn't have even been a piece of information, a data element, right, for the physician to use, right? And that's assuming that the physician is even using that data element as a sort of part of their toolkit. But it's really quite unfortunate for those individuals who have the manifestation of a sleep onset REM during the PSG, because it in and of itself is spurious, right? It's paroxysmal. It's not necessarily trait-like, and so only one quarter of the time, maybe likely less, when they have it, do they actually have it, in sequence, so that it's trait-like. So it's like when you get it, it's a golden nugget. It needs to be treated like a golden nugget, right? And I'm thinking of Lord of the Rings right now. It's like, I'm Schmeagol, right? Like, it's mine, it's my precious, right?
Well, it kind of reminds me, and this conversation comes up so much. Our colleague, Dr. Doug Kirsch, talks about this a lot, that if we distill this entire PSG into an AHI, then yeah, of course. Like, why
What a
wouldn't you do?
waste.
Right.
Right.
And why wouldn't you do an HSAT, right?
Yes.
But
right.
then when we get into these conversations about phenotyping OSA even, right? Is there something in that PSG? Is there just stuff? I mean, we're collecting gobs of data and we're not really, I think, reflecting and sort of assessing it. Kind of like, it sounds like what you're doing, to look for these signals.
Yes, and that in and of itself is a great point, because it's not just cardiorespiratory, right? It's you can't just whittle it down to the cardiorespiratory system. How people manifest symptoms is wildly variable, right? Like I'm sure a patient comes in and their AHI is 161, right?
Yeah.
But they're not, quote unquote, sleepy.
Right.
You're like, wait, that doesn't make any sense, right? But then you have others that come in and their AHI is 7 and they're wildly decompensated, right? And they're so symptomatic. And so there is a precision medicine approach there that we're missing as well. Just when we're looking at treating sleep disordered breathing and then the consequences of sleep disordered breathing, right? Again, because there are gobs of data that essentially are not being sort of used in sort of a holistic way. We're just kind of whittling it down to the cardiorespiratory system. But that is something that is also one of the things that we're trying to do now as well, is to utilize these multifaceted pieces of data to be able to kind of, in a precision medicine way, say this person's going to likely go this way. This person is likely best to go this way, right? From a sort of next step approach, right?
So let's take a short break. And when we come back, we'll talk more about the importance of a SOREM on a nocturnal PSG. You're listening to Talking Sleep from the American Academy of Sleep Medicine.
While attending Sleep 2024, the annual conference for sleep medicine professionals, add these fun activities to your schedule. Join the pack for food and drinks with your peers on Saturday, June 1st at its Lone Star Fiesta. Workout enthusiasts, kick off your morning with yoga, Zumba, and breakfast at Vibe Fusion Fitness on June 2nd. Sunday evening, socialize with food and drinks at Club Hypnos. Register at sleepmeeting.org or on-site when you arrive.
Welcome back to Talking Sleep. We're talking with Dr. Alyssa Cairns on her research on the predictive value of a SOREM on a nocturnal PSG. It sounds like you're focusing on hypersomnias, and yet I heard you say, like 99% of these studies are done for sleep disordered breathing. So why the focus on hypersomnia?
Well, so I'm kind of personally connected to it. I'm personally connected to it, number one, because, when I started this exploration, I said, wow, what an opportunity to explore, these nuances and the things that we don't know with these huge data sets. And so you need a lot of data to be able to do that. But then what really kind of got me interested into it is that I'm a person that suffers from IH. I've had IH since I was 18.
Wow.
And so I came into it with kind of I hate to say the word me search, right? Because it's not, but it's a personal passion of mine, because I can personally relate to the plight and the onerous journey that one has to live with and throughout to get to a final, even that first step of getting to the right provider to look into what is potentially the etiology of what is happening to you.
And good for you for getting diagnosed at 18.
So I didn't get, that's the thing, I didn't get diagnosed at 18. I knew I had something was amiss at 18. I just assumed that it was me that was the anomaly that was sleeping, that needed, right?
Yes.
Needed 12 hours of nocturnal sleep plus a 2-hour daytime nap. I just always thought that that's just the way I was built. And I made my life and my academic life kind of work around my sleep schedule. But if I didn't get that, I was what they say, a hot mess, right? So I would be a complete disaster, right? And so I really needed to have a regimented sleep schedule. I needed to have my own room, right? It's crazy what we have to do. And so I could really personally relate to the unique, quite terrible struggle that it is for someone with IH who doesn't know they have IH at this time.
Well, I thought you were going to pop out some scientific term. I wasn't ready for hot mess.
But that's what it is, right? If you're someone who lives with something where your sleep need is so high, or that the sleep that you're getting isn't sort of scratching the itch, meaning it's not fulfilling the need for sleep in order to function at your optimal sort of status during the day, to perform as best as you can, you have to really structure all of your planning around sleep. And so I was, as a college student, very much tested, right, in that scenario, because I would have to be, pressed with how many hours I could allocate to study and things like that. So when those things didn't get met, I was really, thrown off, being able to really not perform, frankly. And it wasn't because I wasn't prepared. It was simply because my sleep was not, not optimized for me at that time. And it took me another 10 years to get.
It did.
Yes.
Well, but you kind of joked about saying it wasn't me search, right? It was research. But I feel like one thing that we're seeing more of in the last maybe, 5 years or so is more of that collaboration. So
Absolutely.
it's not right, because you're the expert on your body. Like, you're the CEO of your body. And
True.
And I love that idea of collaborating with people who have this lived experience, right? Okay, so I was deep in a thread on Reddit last night, and I follow this narcolepsy thread. And they were talking about how they had migraines. And until they were placed on medication, then all of a sudden the migraines went away. And I've never heard that before.
Yes, and it's a delightful intermix too, because it's one of those things that I can relate in both ways, because not only do I have IH, but I have migraines too. So it's like, once I was able to get treated for those things, I remember it's like a flashbulb memory. I remember the very first day that I had been treated, that I started treatment for IH. I remember the feeling. I remember where I was. I remember the smells, the sounds, the taste, everything around me. I remember that I was getting up into a car, and all of a sudden it was like the lights went on. Yeah. It gives me goosebumps even talking about it. So I just remember that this feeling of alertness was something that I was not used to. I had never experienced it before.
Wow.
And I know. And I was just like, are you kidding? This is what life is? Oh my gosh, this is so exciting.
Well, it's true. And I think that's a conversation we have often in clinic, is like, it's sometimes hard to know, if you are sleepy, because that's how you've always felt. So that's kind of your normal.
Right.
And then it is sort of is it just me? Am I just being a wimp? Right? Does everyone push through this? And it's kind of a barrier.
Absolutely. Right. You become so acclimated, desensitized to your baseline, that you don't know what a normal baseline should be or should feel like.
But that's just it, right? And so then it's a matter of having more of this information and more tools. And I think I've seen more of a willingness to collaborate, on, I can't remember how many of the last committees I've been on, we've had a patient representative, and it's been incredibly helpful. Right.
Because no one knows like they know.
Right.
Yeah, absolutely. So that's, I call it my superpower, right? because when I look at these data and I look at the questions that are out there or the gaps, I look at them not only from a scientist, but as somebody who suffers from this, right? And I can empathize very deeply with the question, but also how much of an impact is that going to make on the potential humans that it touches? And you mentioned migraines, which is, again, this sort of cross pollination that we see between people that have IH, but also the variety of kind of vasomotor symptoms and migraines and pain symptoms and pain syndromes. Again, very difficult to disambiguate kind of what is the chicken, what's the egg.
Right.
But we do know that with IH, idiopathic being kind of in the name, we don't really know what is driving it, but we do have to kind of rule out all the other things that could be potentially contributing to the sleepiness. But we do see a lot of other, orthostatic abnormalities that occur with IH as well.
Yeah,
Migraines
absolutely.
being one of them.
So let's talk about the MSLT. You talked about sort of the testing, and MSLT was meant to look for narcolepsy, right?
So that's a very interesting question, right? So I think, if I recall, I mean, I worked with Mary Karskadden for a long time, years ago, and am still in close contact with her, and had just the blessing of a lifetime to be able to see how her brain works, but also have the ability to hear from her mouth, like what the MSLT and the rationale behind it, right?
Yeah, tell me.
And so for fun, I actually pulled out the very first, I don't know if you can see this here, but I have this hard copy paper binded book, right? And this is circa 1978.
Oh boy.
And it is this amazing manual of, kind of how to conduct a polysomnogram. And of course, part of it is the MSLT and the rationale for the MSLT. And essentially 1978, being under with her and Dr. Dement, the MSLT was created simply and purely out of the need to have an objective test for essentially sleep pressure, sleep drive, and sleep latency.
Okay.
And that's it. So that's why it was created. 1978. It came from an observation that they were, with increased sleep drive, will one fall asleep quicker, right? And then you can put a period in that. Then 1979. They started to do, validation trials. Okay, so how can we really test that this, that this test works or performs what it should be? Well, of course, you take a pathologically sleepy group and test the MSLT against healthy controls or those who have sleep, sated conditions. And it performed really well for narcolepsy type 1 because that's what they had at that time, right? This curated group of narcolepsy type 1. Or with cataplexy at that time, right? Because we know that the criteria has sort of the nosology has changed, but we know that it performed well, and it still performs well, the MSLT, in disambiguating narcolepsy type 1 or hypocretin deficient narcolepsy from those who don't, right? What happened is sort of this sort of unraveling of how the test was intended to be used or simply was designed for, right, into applying it for and extrapolating it to other conditions, right, that are things that we really just don't have a full handle on yet. For example, the narcolepsy type 2, right? Yeah. We don't necessarily know, certainly we don't know what the hypocretin status is. We think they don't have cataplexy ? Because we don't really have in the large scale clinical world a really great standardized way of measuring cataplexy. They may have atypical cataplexy. We don't know, right? So they kind of get sort of into this narcolepsy type 2 kind of bucket. But then this whole other animal, right, is IH. So we've had the MSLT get utilized, proliferated to these other conditions that are under the umbrella of CNS hypersomnias, but they're really quite different, right? We know that one has a known fingerprint, a known etiology, and the other ones we simply don't know.
True.
Yeah. So the MSLT was real. I mean, it was really not created for meaning that was the purpose, was to create it for the test of narcolepsy. It happened to be used to validate the measure, the instrument, if you will, right?
Interesting.
Yeah.
So how can we do better? How can we better identify those with IH? I mean, do we need to do extended PSG? I mean, what do we need to change?
So, I think that, we need to first identify what it is, right?
Fair.
What is it?
Mm.
We still really don't even know what narcolepsy type 2 is, right? We know that sometimes with someone who has really extreme sleep pressure, right? Sort of this sleep drive, but also REMs on the MSLT, they have some kind of narcolepsy. Maybe if you test them twice, it might not. Right. That's another.
That's Lynn Marie's work.
Right. That's a fun fact, right?
Yeah.
So really frustrating. But with IH, in my opinion, I think there is a top-down approach, and I think there's a bottom-up approach, right?
Okay.
Meaning I think that there is almost like an insomnia-like process, right? You would use symptoms, right? It's really about symptoms. It's about how they manifest, patient-facing, sleep habits, sleep inertia, sleep drunkenness, any of the other kind of parameters around the need of sleep, how restoring is your sleep. So that's sort of that clinical dialogue, but a very rich clinical dialogue that needs to occur with validated instruments. For example, the hypersomnia scale, right?
Mm-hmm.
So that would be wonderful to have mainstream into all clinical practice, especially those that have, these symptoms of let's just call it sleepiness, excessive sleepiness that you can't really say is due to something, that you can, kind of anchor to what's happening on the PSG or whatever, right? But I think that the MSLT in that kind of a situation is not going to it's not going to give a lot of information about that person's kind of overall phenotype, because what are we doing on the MSLT? We're testing sleep ability, right? We're testing the ability to fall asleep and how quickly one does, and then the ability for them to go into REM, so that REM dysregulation factor. And I think that if you think of IH from the person, from the human, from the patient, I can tell you that there is a constellation of symptoms that are quite unique with a person that is, IH in its classical sense, that would be suited best to be tested outside of the sleep lab entirely, frankly, right?
Yeah.
So it's continuous monitoring in the home, right? To see kind of what is their sleep efficiency, or how many times are they lapsing to sleep or not. It's really disentangling sleep ability from wakeability, right? And so you can only really do that by long-term monitoring. And so that can be done in the home. You could use potentially consumer wearables if they, have the right sensitivity and specificity, along with sleep diaries, as well as, the functional outcome domain, because that's the critical piece, just like insomnia, right? It's not how many hours of sleep did you get, or how many hours of time in bed did you get?
Right.
How did you function? How did you feel? And those are the pieces, I think, that are really critical from that top-down approach that are going to help us move that needle in the IH space. I think there are bits and pieces, nuances, if you will, within the polysomnogram that can be utilized, but the data to date are just wildly heterogeneous, because what are we doing in a routine PSG? We're restricting these people to, at best, an 8-hour time in bed. At best. But usually it's more like 7.5. Boy, I mean, you're cutting off those natural inflection and deflection points where they would be, falling asleep and waking up. And those are the rich points, right? Those bookends, if you will. And so without those critical pieces of information, we can't really, right now, utilize these huge repositories without seeing the natural life cycle, if you will, of their ad lib sleep, which is why David Plant is a huge advocate for doing this almost ad lib paradigm, to see within the nocturnal polysomnogram, let them sleep, right? Let them fall asleep when they want to. Let them wake up when they want to.
Yes.
That's really challenging in the mainstream clinical atmosphere, it's just not set up like that because of all of the complicating, got to change over technologists and the billing and right, there's a lot. So it doesn't fit, right? In the current paradigm for testing for IH, if there was such a thing, it doesn't fit with how a human with IH presents, right?
You're exactly right about that. We used to, I have a very, very small clinic, and we used to be able to just let people fall asleep when they wanted to and wake up when they wanted to. And not just for IH, but also for shift workers.
Exactly, yeah.
Because we were doing 12-hour shifts and because we had people, and because, quite frankly, because it's just me. So it's a very small clinic. And so we had that liberty, and now we don't. And
Yes.
I do miss it.
Exactly, right. And I'm sure that the patients do too, right? Because they're the ones who can't show you their true colors, right? They can't show you what's really going on. It's like doing a blood test and not testing for, A1C or something. Like you're missing a critical piece of the root cause, or potentially identifying the root cause.
So tell me, what is it that we get wrong about IH?
Well, number one, we don't know what it is. Number two, we don't know how to define it, right? So if we don't know what it is, we don't know how to define it. We don't know how to make a test for it. For IH, what's I think most unfortunate right now is when we apply the PSG that is artificial. Again, you're curtailing the sleep period to, whatever, 7-8 hours maybe at best. And then you have a next day MSLT, and many times it's kind of like this diagnosis of default, or kind of a diagnosis of exclusion, right? And it might not, that doesn't fit. That shouldn't be the way that we are looking at IH, right? We need to define ways, methodologies, in the absence of a biomarker, to be able to test, like I said, in either the home environment or with longer term monitoring in the laboratory environment, to get those rich cortical signals, to see what is potentially going on from a root cause perspective, but to not utilize this current, right, sort of, like I said, this chunking approach, right, this PSG MSLT. It does not seem to encapsulate that person's disease process, in my opinion.
Well, and it's funny because I recently did use a DSM-5 criteria for IH for someone who, takes a while to fall asleep, and then sleeps like 11, 12 hours, and then takes like a 2-hour nap. And so
they were me.
Well, right. and so I'm, so I've submitted everything, and insurance is so challenging, because sometimes they want you to say, well, what was the results of the MSLT? And they're, I don't know whether I'm just not phrasing it right using the DSM-5 criteria, but I delineated the entire thing. And so, but it's kind of maddening.
It's maddening. It is the right word. It's maddening. And it's unfortunate because it's taking all of the years of tutelage, right, that you have, the expertise that you have, and diluting it to something that is quite arbitrary. And there's no one that's going to know that patient better than you, the care provider, the educated, specialized care provider, and that human that is suffering from the condition. And so it really comes down to the insurance companies and also the intermediaries of these third payer parties to be able to allow the practitioner be a practitioner, right? And I know that we can't just open it up to sort of, kind of anything and everything, but it has to be based on evidence that at least this paradigm doesn't work, right? And based on my clinical judgment, based on the amount of time that I have spent in the clinical interviewing process and, ruling out other root causes, this is my clinical determination. And so that should be fact enough, at least to either rationalize additional testing or to allow this person to have the therapy that they so need. And if they respond to it, that's evidence right there.
Yeah, if you can get it. Yeah, and the thing that's so frustrating, right, is like no matter how frustrating it is for me or how many days it takes for me to calm down before I can respond to some insurance letter,
right? I know.
The burden is obviously disproportionately, it falls to the patient.
Yes, and it does. But we're grateful, even as I'm saying this as a patient, right? We are grateful for you fighting the good fight. Because if we don't fight the good fight, if our providers don't fight the good fight, if the researchers don't fight the good fight, we will not make policy change, right? And so I think that is the next step, is additional research, additional, kind of in the best way possible, kind of bulletproof case that we can get to a policy change, paradigm shift, right?
In advocacy.
Exactly.
I think the last Hill Day I did, we had patient advocates on our panel, and I thought their stories were so compelling.
Absolutely. Yes. So anything that we can do, both patient-wise, researcher, also coming together as a multifaceted team, right? Like you said, right? So it's the patient's perspective, it's the research, it's the science, basic science. It's also the clinician with decades of research and experience under their belt that comes with an envelope of information that is essentially bulletproof, right? Or at least let's try this to see if it works. Working as a team, building bridges.
So any final thoughts for us?
Well, I'm hoping that this conversation at least will have, if we kind of just think about the nocturnal PSG, my hope is that the one thing that I can at least share from the information that I have been able to see with the prospective trial that I conducted for, again, it was observational, was to really challenge the practitioners that are interpreting these studies that do indeed find that their patient has a sleep onset REM, to really challenge them to use that information and to make a clinical decision that is potentially more nuanced than, like you said, cardiorespiratory related, right? Because we have so much information that is supportive, wildly supportive of the sleep onset REM being predictive of, narcolepsy, essentially, right? Because what we found was that even though very few individuals went through from that study to get an MSLT, right? They were essentially all on that high extreme tier of narcolepsy, meaning they had 3, 4, even 5 REMs. Yep. Yeah. So out of the 30,000 studies that we processed to detect sleep onset REM, about 1%, just shy of 1%, actually had the sleep onset REM. And if you follow that all the way through, only 5 individuals, 5 out of 178 with sleep onset REMs, went on for an MSLT that was prompted, right? That was prompted from the information, but nearly all of them had MSLT results that very much confirmed what we suspected, right? So that it's another way to slice the pie. But what we also found in the exercise was that the majority of physicians did not sort of make a move, right? They saw it. They saw that the patient had the sleep onset REM, but they oftentimes would associate the sleep onset REM with either having sleep apnea, right? Yeah. Having PLMD, or perhaps question mark, did they have enough sleep the night before? And there is literally no data right now that supports that nocturnally, now this is different than diurnally, but nocturnally would REM occur within 15 minutes unless something was amiss at the sort of REM flip-flop switch level. And so my hope is that this information even just reaches one physician when they come across this information to really critically evaluate that, whether it be immediate action or at least information that for the next time they see the patient, that this could be this could make a life change for that human, and to not dismiss it.
Wow. Well, thank you so much for joining us today and to help us better understand not only some of the clues that we might be overlooking in our patients who undergo a polysomnography, but really for trusting us with your diagnosis and being willing to share your personal experience as a person with IH.
Thank you so much.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.